Research informs clinical practice, which then gets spread, and the clinical practice then takes off and develops new questions for the next round. And so the winners in all of that, of course, are the patients who benefit from continuous improvement of the care that they're receiving, and the medical community as well for the continuous learning that research provides.
I think the expectations of consumers have changed as a result of the pandemic. This notion of proximity, I think, is a lot more present in the conversation. Consumer expectation that the health system will reach me wherever I am, no matter where I am, is something that I think is something that's here to stay and will be part of what we do in the future.
Welcome to the 2023 season of the Permanente Medicine Podcast. It's great to be back with an exciting new season, talking once again with leading voices in healthcare. I'm Chris Grant, your host, and the Chief Operating Officer of the Permanente Federation. For our first episode of the new season, we're taking a look at the latest advancements and challenges facing quality improvement in medicine and care delivery. Our guests today are incredible leaders and influencers in the field, and I look forward to hearing more of their insights on the topic. Joining me is my colleague and dear friend, Dr. Nancy Jin, Executive Vice President of Quality and Chief Quality Officer for the Permanente Federation. Dr. Jin was named one of the top 25 innovators in healthcare by Modern Healthcare in 2022. She also serves as the Medical Director of Quality and Clinical Analysis for the Southern California Permanente Medical Group, where she oversees quality and patient safety. Also joining me is Dr. Kedar Mate, who serves as President and CEO for the Institute for Health Improvement. Dr. Mate is also President of IHI's Lucian Leap Institute and a member of the faculty at the Weill Cornell Medicine in New York. Welcome, Nancy and Kedar. It's a pleasure to have you both on the show today.
Thank you so much, Chris. It's really a pleasure to be with everyone today.
And let me just echo Nancy's comment. Chris, it's a pleasure to be here, and thank you for having me.
All right, well, let's get started and have a good time. I want to know a little bit more about both of you and the world you work in. Can you each tell me a bit about your role and how advancing quality of care plays a part in your lives? Nancy, let's get started with you.
Thank you, Chris. I think that everyone who goes into healthcare has at their core a deep commitment to quality. They may not be able to articulate that, but you go into healthcare because you want to make a difference in people's lives in a positive way. And that really is what quality is all about. So to me, it makes it so easy to spread the message, share the information, get people galvanized around quality efforts. In my roles, I am focused on organizing across the Kaiser Permanente program the quality endeavors that are important to our members and to the outcomes in their health. We adhere strongly to all of the IS measures. We follow Medicare 5-star, and we are really focused on ensuring that the quality of care is the highest wherever patients receive their care throughout that continuum, and promoting safety. I'm also oversee in Southern California research operations, and there is such a strong connection between how we continue to advance quality and the important role that research plays. We create the systems of care within our integrated organization. I have an ability to create those systems that frankly, no one else in the country can. And through that, we learn and demonstrate what is possible in terms of true population health, because we are able to do that at scale with our 12.5 million members.
Thanks so much, Nancy. I can't think of a more rewarding role in healthcare than leading quality and clinical improvement. Kedar, same question for you. At the Institute for Health Improvement, tell us about your role and how you're advancing quality of care.
Well, Chris, I agree with you. I think working on quality is one of the most important things that we can do as clinicians and as healthcare professionals, and it's a very special opportunity for us all to be involved in, as Nancy so clearly elaborated. Bit of background. I got my start in global public health. I was working in very resource limited settings in Haiti and Peru and Rwanda with an organization called Partners in Health. And, what happened during my time, we were working on a tuberculosis treatment program in Peru. And we were very successful at taking care of individual patients. We could treat their tuberculosis. We could make them healthier. And we would start the clinic at 6 a.m. with a long line of patients out the door. And we'd end the clinic at 6 or 7 p.m. with a long line of patients out the door. And there was an issue that we were facing that we weren't able to solve. We were able to take care of individual patients and treat them very successfully with high quality care, but we weren't actually solving the systems challenges that we were experiencing that was leading to the chronic queuing that was occurring at the gates of the clinic every day. And it was in that experience that I first met the Institute for Healthcare Improvement, the organization that I now work for, which had pioneered methods of quality science, learned from industry, and brought them over to healthcare to solve problems of healthcare timeliness, patient-centeredness, systems challenges of reliability, and clinical effectiveness. And we started applying those methods in that context and started generating improvements in how systems perform. We were able to solve those long lines, improve conditions that people were living in, and at the same time take better care of them clinically. And so I think of quality and what we do in the world of quality as not only providing high quality clinical care, but also solving a lot of the systems problems that trouble us as clinicians on an everyday basis that make it very challenging for us to provide the kind of care that we're well able or well equipped to do. And the Institute is specialized in this. This is what we do. We create new models of care. We innovate in the development of those areas. We work at the leading edge with partners like Kaiser Permanente, like Nancy. We work with partners in the field that are at the cutting edge of quality, patient safety, healthcare value, and now health equity to try to deliver better performance in every clinical encounter.
Thank you, Kedar. IHI is an incredible organization, transforming healthcare in such a profound way. And, your story is so familiar. I don't know of a medical mission that doesn't come back with almost the identical story where they cared for so many individuals, but the line was out the door and they couldn't care for everyone. And so finding that pathway to the root cause and making systematic changes to the environment is such an important component.
And we have versions of that story here in the US, right? I mean, we have versions of waiting, whether it's waiting times or the system reliability in operating rooms, or how we actually move patients through our system, the delays in care that we experience in the emergency room or otherwise. We have versions of that story in all clinical environments. And at every point in time, we find these small things that create those delays that clinicians actually have a role to play in problem solving around, but they often don't have the vocabulary of system reliability that they can use to solve those problems. We know how to take care of patients, but we don't know how to treat systems. And that's what quality science is all about.
Yeah, such a great point.
Say one thing here that, one of the other benefits, I think one of the other motivators in developing these systems is not just for the people that we're serving, but it also helps the teams who are delivering that care. I think right now we are seeing unprecedented levels of burnout in our healthcare system. And having systems of care that help to support the teams to deliver high quality outcomes take some of that responsibility and that direct burden off of their shoulders and help them do that so that they can do the work that they need to do with the members and helping them and the patients and helping them be the healthiest they can be. That systems approach can really be life-saving for them. So that's where their input becomes so important.
Oh, that's absolutely right. And I think that's a great segue into my next question. Over the last few years, the COVID-19 pandemic has dramatically transformed healthcare delivery, as well as created barriers to quality care because of the limitations of in-person care, especially during the lockdown. In your view, what has changed the most about care delivery during the pandemic, and how do you expect these developments to impact patient care moving forward? Let's begin with you, Kedar.
Yeah, this is a great question. The Probably the most obvious response to this question, of course, is the growth of virtual care. Obviously, virtual care is here to stay. I think pre-pandemic, most systems were dealing with, single-digit percentage points of the number of encounters that were taking place in the virtual arena, 1, 2, 3% of their total care volume. In the intra-pandemic period, especially in the beginning, that went up to 30, 40% of care encounters in that environment. And some things have returned, come back down, but obviously a lot has remained virtual and will remain virtual in the future of care delivery. There's a lot to say about how to make quality better in the virtual care environment. In fact, in IHI's Leadership Alliance now, we have, for the first time in the 10-year history of the Leadership Alliance, we have several virtual care companies, organizations that specialize in this area that have joined the Leadership Alliance as direct care providers. So they're like the rest of the participants, they're also providing care, but they're doing so at the, as they call it, the website, which is a word that I learned in the last couple of years. And a lot of the questions that they're asking is, how do we even know whether or not the encounter is high quality? We have architected teams in brick and mortar healthcare institutions, teams that Nancy leads at KP, of people whose job it is to ensure that we're providing high quality, safe care that's high value to our members and beneficiaries. But we don't have a similar set of teams when all of the care is being provided virtually. So how do we extend this notion of quality into the virtual arena and ensure that what we're providing is at a standard that we would all regard as being equivalent to, if not better than, what we can provide in person? So I'd say two other features I'll briefly comment on. One is that I think the expectations of consumers have changed as a result of the pandemic. This notion of proximity, I think, is a lot more present in the conversation. Consumer expectation that the health system will reach me wherever I am, no matter where I am, is something that I think is something that's here to stay and will be part of what we do in the future. And then the third thing I'll say is a feature of care delivery that I think the pandemic, again, didn't necessarily cause, but has exacerbated, is what Nancy referred to earlier, the workforce challenges that we've experienced. They existed well before the pandemic, but I think the pandemic has only served to help us recognize the challenges that we have placed on the workforce and the need for us to pay attention to the workforce stress that is experienced on a daily basis.
Thanks so much, Kedar, and I love your insight. And you're right. The workforce, physicians, nurses, allied health professionals, the receptionists, the custodial staff, all have been the foundation of healthcare through the pandemic and endemic phase, where there's tremendous demands on the system, and everyone can rise to the occasion. But rising to the occasion for year after year after year in such a complex time with such high demands is difficult. Dr. Jin, this is such a fascinating area. I am super interested in your insight.
Well, it really is fascinating. And, I wholeheartedly agree with everything that Kedar said, and you as well. Actually, interestingly, in the earliest phases of the pandemic, some parts of our own organization in Kaiser Permanente saw a flip from 20% virtual to 90% virtual. Now, it's not stayed at that level, and we're not actually really sure what that balance of virtual versus face-to-face care is going to be. And it's going to be driven a lot by consumers and what they want. But what that has meant for us is that it has shifted our ability to provide at times that population level care when we are doing disease prevention and chronic disease management. So oftentimes it was predicated on a member or a patient coming in for something, for instance, eye exam or blood pressure check. And while that person is here, we would make sure she'd get her mammogram or update her labs for her diabetes or counsel her about other facets of her health. That's harder now to do some of those when someone is virtual. And so it's caused us to have to really become even more creative and in some ways figure out ways to engage our members and our patients in a different way to entice them to come in to get those care gaps closed so that we can make sure that we're optimizing their health. One of the issues that we're also dealing with right now, and it's not going to be a long-term it is directly related to the deferred care that occurred during the pandemic. As one example, in Southern California, during the first of 4 months of the pandemic back in early 2020, we saw a 59% decrease in follow-up for diabetes and a 91% decrease in mammography. And while each subsequent period between surges saw an increase of return of patients to getting those care gaps closed, they never quite matched up with the losses that occurred when people stayed away during the surges. Now, of course, the flip side of this coin is that there have been a tremendous receptivity, both on the part of the consumers, the patients, and the providers to embrace technology out of necessity initially, but now that it's been socialized and there's a comfort level, they're now becoming more creative around this. We are putting into place quality assessments so that we can address those issues. Is the care that we're providing virtually at the same caliber or getting the same kind of outcomes that we need? But the equitable aspects about what virtual care can provide are significant. We just published an article in JAMA Network about our home-based cardiac rehabilitation program. And in it was identified that 45% of the patients receiving home-based cardiac rehab were people of color, and that the outcomes are actually better than face-to-face because the patients were 75% more likely to complete the rehab when it was virtual than for those who have to come in face-to-face. They say creativity loves constraint, and this is a really good example of how we can leverage something like a pandemic to our favor.
That's great. That's a great example of using technology and innovation to close care gaps in a meaningful way. You know, I also love your story about proactive office encounter. I do worry. Probably one of my biggest concerns is around deferred care across the United States and across the globe. I'm going to continue with you, Dr. Jin, here. In 2022, you wrote a commentary in a peer-reviewed medical journal that referenced what you call virtuous cycle. I love that terminology, which centers around the relationship between research and clinical quality. Can you share a little bit about your ideas and speak about what you meant by virtuous cycle and the link between research and clinical practice?
Absolutely. You know, the article was written principally with physicians in mind, but I think it really applies to all who are delivering care. In medicine, we have to be lifelong learners. When we graduate from medical school and residency and fellowship, we do not for one moment believe that the information that we've learned to that point is going to be it for the next 30 years. Medicine is a dynamic and ever-changing field, and the physicians and the clinicians and all members of the teams follow with that. The clinicians and physicians do also see opportunity where there are questions about what's the better approach, which medication is more effective, which technique will get a better outcome with less morbidity. And those questions then inform the research community. And so we have in our program an extensive research component because we recognize the value and importance of having that clinical question inform the research that we do. So many of our clinicians actually are researchers as well and are involved with grants and also involved with process improvements. And so that is what creates that virtuous cycle. The research informs clinical practice, which then gets spread, and the clinical practice then takes off and develops new questions for the next round. And so the winners in all of that, of course, are the patients who benefit from continuous improvement of the care that they're receiving, and the medical community as well for the continuous learning that research provides. But it's all predicated on having clinicians who are willing to make those observations and then provide that feedback to the researchers about what they would like to learn.
You're so right. Linking kind of the traditional research to the operations of care delivery and the practice of care delivery, and creating this feedback mechanism is ultimately what is transformative. It's the partnership and the alignment and the continuous loop of both.
Chris, just a really brief comment on this. But first of all, Nancy, thank you for elevating this and with your colleagues in your article. This, I think, is at the heart of what the Institute of Medicine or National Academies described as the learning health system, right? This is the concept was to utilize our best assets in our systems that can do effective discovery work on the research side and link it to the clinical questions that matter most, and to do so in a manner that's always and continuously informed by patient need and requirement. And that combination has the capability of changing what we do.
Kedar, you are the envy of every physician leader in quality in your role at the Institute for Health Improvement. I mean, can you imagine? You get to spend every day of your life focused on how you can improve healthcare across so many systems that rely upon IHI, but also across the globe. Can you tell us about some of IHI's current efforts and the things that you're doing that you're most proud of?
Wow, what a generous question, and thank you for asking it. It is really a thrill, a privilege, and an honor to have the chance to work with so many dedicated healthcare professionals, quality experts, scientists, leaders, frontline care providers all over the world. IHI now works in about 40 countries in every state in the United States with systems all over the place. And some of the things that I'm particularly excited about right now are our work on health equity together with the American Medical Association, the American Hospital Association, Race Forward, and a number of other organizations. We launched a coalition that's trying to build momentum and create alignment in the field of healthcare to focus on health inequities and start to tackle them. Very specific clinical inequities that we see in our work, that in cardiovascular care and diabetes care and cancer care, that are solvable. These are solvable problems. We've proven now with hundreds of partners across the world that we can work on these issues using quality science, using the methods that we have perfected in quality improvement and patient safety, applying those same methods to this, ever-growing challenge of health inequity. So the Rise to Health Coalition is the name of that coalition that we've put together with the different parties that are here that I mentioned earlier. And over 100 health systems have signed up to be part of this initiative. And we're also paying a lot more attention to patient safety. We've seen a significant regression around patient safety during the course of the pandemic. Lots has been written about this. CMS was quoted as saying we've erased 10 years of progress in patient safety in the 2 years of the pandemic. So there's lots of backsliding that's taken place. So we've got a lot of opportunity, and the staffing challenges that we all know about and have been talking about only serve to compound that safety challenge that we have right now for patients. So it's my view that a lot of what we've done in patient safety over the last 20 years has been reactive and retrospective. We've looked at events as they've occurred and analyzed them, and then try to build systems that avoid those kinds of failure modes in the past. That's where high reliability systems used to be 20 years ago. And we have a lot of work to do, I think, to progress patient safety to the next generation of proactive risk sensing and awareness, and using our information systems to actually identify and anticipate where a harm event might take place before it happens. Not reacting to it afterwards, but actually seeing it before it takes place and proactively mitigating before the unsafe care event takes place. And then the last thing I'll mention to you here is some work that we're doing right now on climate and health. It's become really clear to me just how much of a quality and safety risk climate change poses, actually, and just how much healthcare actually contributes to climate impact, which I wasn't terribly familiar with about a year ago. But it stands to reason that 20% of our economy would contribute a significant portion of greenhouse gas emissions to the overall effort. So there's some work that we've done with a group of experts to help healthcare decarbonize. And by doing that work, we not only can help green our planet, but we can also mitigate the health impacts of climate change that we end up experiencing in our emergency rooms and in our hospital settings.
All super, super exciting. And it actually gives me a lot of comfort because many of the areas that you highlighted are such high priorities for Kaiser Permanente as an organization, whether it be the effects of climate change and the obligations of institutions and governments and communities to proactively understanding and addressing health disparities to safety.
I just love, Kedar, that you've identified the impact that healthcare has on climate and how much climate impacts healthcare. It's been one of the points of pride for me since coming to our organization that we have a huge commitment to climate. And buildings that we now put up have to be LEED certified. And it has been inspiring to see groups from OR teams to floor nurses really looking at the waste generation and trying to influence purchasing of more carbon neutral and earth-friendly products. So I just can't encourage us strongly enough to continue in that quest.
Fantastic. Thank you, Dr. Jin. In discussing quality improvements, the pandemic has really highlighted how it goes hand in hand with addressing health disparities. We could dedicate a whole episode to health equity, but I'm hoping you can tell our audience what you see as the biggest challenge for healthcare in addressing health inequity when it comes to improving quality of care. Nancy, let's begin with your thoughts.
Thank you. We could spend all day on this topic. It is so timely and so pressing. But really, when we think about a quality of care in this country, we are not going to ever fully realize that goal until we've eliminated health disparities. Our commitment in Kaiser Permanente to that end goes back at least 15 years. We have data that demonstrates back in those days and continuing on our longstanding commitment to end health disparities. Of course, with the increased intensity of focus nationally following the death of Mr. George Floyd and the accelerated commitment by healthcare overall, it's been really gratifying to see more partners in this work and opportunities to collaborate to end disparities. From NCQA to Joint Commission to CMS, and then most recently, the inspiring work that you're leading, Kedar, at the IHI, the Rise to Health Coalition. The central component of this is really elimination of disparities. It is something that everyone can be galvanized around. I think for us, the drive to health equity really has to start with a willingness for self-reflection. We have to be able to ask ourselves the question if the care that we're providing is actually equitable. So it means that we have to be able to look at our own outcomes broken down by cohorts, not only of race and ethnicity, but primary language, social determinants. There are a variety of ways that health inequities are manifest. And we need to also recognize that those social determinants are really directly related to 140 years of systemic racism and bias in our country. So we're not going to fix it overnight, but if we can start to self-reflect and identify, then we can come together through coalitions to ensure that we are addressing social determinants as drivers of health disparities and that crucial link to the elimination of inequities.
Dr. Jin, it's such wise words and really quite simple, right? The path to health equity starts with self-reflection and a willingness to really look within systems that have existed often for decades and be willing to address challenges, problems, and not sweep them under a carpet, but really confront them in a profound and honest way. Kedar, I'd be really interested in your guidance and insight.
I agree with your central point around self-reflection being the starting point. Data helps with that self-reflection. It's important for us to have information Because I think our natural tendency as human beings is to believe that we are treating people equitably and fairly and justly in our clinical practice environments as well as in everyday life. But the truth is that we are part of a social system, each one of us independently, that has been constructed over many, many generations. And that has resulted in all of us carrying with us biases, whether we know it or not. And most often we don't know it. They're unconscious for the most part. So it helps us to be able to recognize those biases by having information, by having data that helps us to learn about how our systems are actually unfairly treating certain individuals or populations, whether based on race or sexual orientation or gender or rural versus urban or based on political affiliation or a variety of other factors, right? There's so many different ways in which we can understand the disparities that are present in our world. But unless we have data that helps us to see that, we would not understand that readily. And in order to get the data, we have to make the pursuit of equitable care a priority for our organizations and for us as individuals. So I often start our work on quality and equity by saying that we have to make equity a strategic priority for our organizations and for our teams and for ourselves as individuals. Once you make it a priority and you make a conscious decision to start looking at the evidence as it is, the data as it is, you will find inevitably, I've never met a system that hasn't found an inequity somewhere in the system, whether again, rural, urban, gender-based, race-based, otherwise. There's something in your system today, I promise you, where there is an inequity that's present. And here's the comforting thing, or what I take comfort in, having been working on this now for several years. Whenever we find an inequity and we provide that data to clinicians that are earnestly trying to create better care for people, clinicians take action on that information because it is so natural to them to see themselves as wanting to deliver high quality care to everyone that they encounter. That when they see a disparity that's present in their information and what they're doing, they can't conscience that disparity. They can't abide by it. They can't sit idly by it and let that disparity or that inequity persist in their care. They will do something about it, inevitably. And that's what I take comfort in, because every single time we provided that kind of information to teams, and we've done it hundreds of times, teams take action. And the really exciting thing is that once they do that, they can close an inequity gap or a disparity gap very quickly. So the challenge for me isn't a technical one. We have the tools and abilities and knowledge and skill to do this. It's primarily one of whether we're willing to face into that self-reflection that Nancy, you spoke about.
You both give me so much hope for the future. I love listening to both of you and not just your thoughts, your ideas, your observations, your insight, but your commitment and your passion around this. I've enjoyed talking with both of you so much. I truly could go on for hours and hours. It's one of my funnest conversations. You're each such inspiring leaders and shining examples of what the future of patient care is all about and why it's so bright. So I want to thank you for calling in today, Nancy and Kedar. I'm grateful for your time. I'm grateful for your leadership, and I'm grateful for the impact that you both are having on healthcare.
Thank you so much, Chris. It's been an absolute pleasure being with you and Kedar today in this discussion, and I look forward to more discussions in the future.
Well, thank you, Chris. Thank you so much for the opportunity to be here. Thank you to Nancy as well for the opportunity to share the microphone as we're together.
And thank you once again to our listeners for tuning in. We hope you enjoyed this episode and will take the time to subscribe or share a review. We'll see you next time. The opinions expressed on this podcast are those of the speakers and are not necessarily the views of Kaiser Permanente, the Permanente Medical Groups, or the Permanente Federation.